Good afternoon and welcome to the 20th webinar in the MJHS Institute Interprofessional Webinar Series. It is my pleasure to be with you today. I'm Myra Gleischen, the Director of Medical Education, and I'm going to be discussing family meetings in hospice and palliative care. I wanted to say a special word of welcome to our colleagues from Canada, from Hawaii, from the VA, from all across the country, and I'm also delighted that we have some residents and fellows and other trainees with us today who began their training just last week. We are delighted to have you with us and feel that it's a very important opportunity for us to be training you as the next generation of specialists. And I'm pleased to tell you that I have no financial disclosures for today's talk. Well, what I would like to do today is to go over the family meeting as a best practice in palliative care and hospice. The reason why this is important is that family caregivers provide substantial care to patients with serious illness, but are themselves in need of care. Family caregivers are involved every step of the way across the trajectory of illness, including the end-of-life pathway and the time of imminent death and dying. And they're involved in direct care, decision-making, goal setting, and advanced care planning. As professionals, it really is incumbent upon us to integrate caregivers into the plan of care and support them in their roles. And so what we're going to be doing today is looking at what are the definitions of the family meeting in palliative care and hospice, what is the purpose of family meetings, what are the triggers, and are these different according to the setting in which we're practicing. I'd like to share with you some challenging clinical scenarios and end with best practices. But there is some breaking news that I felt that I should share with you first, which is very, very exciting. Today, Medicare announced their plan to reimburse doctors, nurse practitioners, and physicians' assistants for advanced care planning discussions effective January 1st, 2016. This is going to include meetings with patients and caregivers. There is no limit on the number of conversations and the number of meetings, and this will be voluntary for patients, so it won't be forced upon them, but it will be available. And it really is important because it recognizes and validates the importance of communication and family meetings as core skills in palliative care and hospice. There is going to be a period of 60 days in which Medicare CMS will be taking public comments. And this is a very good opportunity for us as individuals, as professional associations, and consumer groups to let our voices be heard in support of this plan. We do hope that social workers will eventually be covered as well, but this is a big step forward because Medicare is a trendsetter, and Medicare covers 80% of deaths in this country every year, and often private insurance follows what Medicare does, and so we just applaud these efforts. And obviously, you know, this is important news because it is so directly related to what we'll be talking about today. So when we use the word and the term family meeting, what do we mean by this? Well, interestingly enough, no single definition exists currently in the literature. We know that it's a valuable clinical tool for communicating medical information, delineating the goals of care, and helping to make decisions in which family members and professionals and the patient, if the patient is able to participate, can end up with some sort of consensus and all be on the same page. It's a very important setting in which to pay attention to the preferences and values of the patient and family, and if done well, should be a safe setting in which caregivers can process emotions. And the family meeting really can be called by anyone, by the patient, by the family, or by the staff. Generally speaking, a family meeting means interdisciplinary participants. It's usually a physician, a nurse, a social worker, the patient, and the family, and people have discussed it and defined it a little differently, but you'll see here the definition by Curtis is similar in that it's to cover the diagnosis, the prognosis, to revise what are the goals of treatment and have they changed. There could be indications for having family meetings at multiple points during illness and leading to palliative care and possibly death. And it is important to check in again and again and see if those goals have changed and how these resonate with the needs and preferences of the patient and family. In addition to those definitions, there's a very important purpose in sitting down with families and in whatever setting we practice. And that is that this really facilitates communication between a team and family in a way that is different if it is done individually, one-on-one, or on a curbside basis. It can and should strengthen the therapeutic alliance between the team and family family caregivers will often tell us, years afterwards, how important it was to have a family meeting when they were trying to decide or deal with what was happening to their loved ones. So it really does have an impact on families. It is also a very good forum for us to perform an assessment, a comprehensive assessment of the family. Who is this family? Who are the caregivers in the patient's life? Who speaks for the family? Or what are their strengths and needs? Are there risk factors? Should we refer to other disciplines, and what resources do we think they'll need? It is a really important forum for that and to support the family as we help them to develop a plan of care. In looking at the literature, the family meeting has been best studied in the ICU setting. Most of the work has been done, and it's also the earliest, so we have the longest experience. The triggers in the ICU for a family meeting are generally within 72 hours of admission, especially if it's a patient that's been in the hospital 10 days or more and has just been transferred to the ICU. It's for patients who have a mortality risk of more than 25% and have had a significant decline in functional status. It is often for patients who are 80 years of age, although nowadays we may need to revise that number and make it even older, and could be and generally is for patients with 2 or more life-threatening comorbidities. Often in the ICU setting, it's to discuss procedures. Should this patient receive a trach, a vent, a feeding tube, and it could also be a venue in which to introduce hospice. In palliative care, the indications for a family meeting could be to make a major care decision, also because of a longer length of stay, perhaps because of a family conflict or family distress or some kind of crisis, and a lot of times because we recognize as a team the absence of a designated healthcare agent, and we think a family meeting would be the best forum to discuss that. It could also be, and often is, a place to share new prognostic information, some of which may be unwelcome to the patient and family. And in hospice, a family meeting could be called because there's an ethical dilemma, we're trying to resolve conflict, to solidify patient and surrogate decision-making, or because there's a change in medical status and we have to discuss transition points in care, for example, to a long-term care facility, to home care, to a hospice resident, and so on. Looking at best practices, there really are 3 distinct phases in running a family meeting. the preparation phase, the talk phase, and the follow-up phase. And I'd like to run you through those briefly. It is really a good idea to take a lot of time for pre-planning before running the family meeting. And this could be pretty time-consuming, but it will really pay off by becoming prepared. By that I mean review the medical chart, speak to team members, current and former. If we are meeting a family for the first time and they've had a home health aide taking care of the patient, it's a very good idea to include the home health aide. Perhaps there's been a visiting nurse who's been very involved, or a primary care physician, as well as specialist teams. So we should get input from all of those people, former and current team members, and make sure to get input from different disciplines, because each discipline will bring a slightly different perspective to the situation. If possible, it is good to arrange for a quiet space, for dedicated uninterrupted time, meaning we have to switch off our phones and beepers and computers so we can really concentrate and be there in the moment. We should arrange the chairs in a circle and make the best use of the environment and the available space. I've run wonderful family meetings in a person's dining room, which was attached to a kitchen. I've run good family meetings in patients' rooms and also in the waiting room of a radiation therapy clinic. Not optimal, but everybody was there. It was the best moment, and we made the best use of the space. And very important decisions to make before starting the meeting are these, because they will influence the outcome. Who leads the family meeting? Who speaks for the family? Who should be invited? Whose agenda is going to be followed if it's different from the professionals and the caregiver's point of view? Who will take notes? Who will summarize the meeting in the chart? Is there a special form? And who will read those notes when they're placed in the chart? Generally speaking, less is better. There should never be more staff than family members, and everybody who participates should have a distinct role to play. In our experience, it usually takes at least an hour of prep time, an hour for the meeting, but it could be longer, and 30 to 60 minutes for follow-up. And the optimal choice of participants would be the patient in most settings, the caregivers invited by the patients, and healthcare professionals who are involved in the case. The next phase involves the actual talk phase. And whoever is leading the meeting should introduce the purpose of the meeting. It could be the physician, the nurse, or the social worker, or another member of the team, and anybody who does it should introduce why are we here in a very conversational tone so that it is less frightening for family members and so that the agenda is transparent. We arranged today's meeting to consider discharge planning options. Is this your understanding of the purpose of the meeting? And sometimes you may have to negotiate. It's important to introduce everybody who's there, go around the room and have people say who they are. And this includes people who may join the meeting late to stop and say, the nurse is joining us, could you please introduce yourself? And if there is a difference or the family has some other agenda items, it's good to have an open mind and be flexible and add those to the agenda. During the talk phase, the person who is leading the meeting should provide information and invite other disciplines who are present to give information from their perspective as well. As we do that, we need to stop, take note of the emotional effect of what we're saying on patients and caregivers. I see that you're having a reaction to this news. I'm sorry that this is not the news that we were hoping for. Check for their understanding. Do you know what this means? Have you heard these terms before? And would you like me to explain further what to expect? Provide support for patients and caregivers along the way, and validation for caregivers. They tell us so often that they felt so neglected and invisible, and that the family meeting really made them feel for the first time that they were part of the unit of care of the patient and caregiver. As we discuss treatment options during the family meeting, we should provide recommendations that are clear which treatments will be beneficial and which may be futile and therefore not recommended. And as we do this, we will see and we should continually evaluate the patient and family's decision-making style. There are some specific competencies that I wanted to highlight during the family meeting that really pertain to how we bring caregivers into the mix. And the first is that the family meeting really does validate the central role of caregivers, and it's a very good forum for doing that. In order to do that, we need to create a safe environment for goals of care discussions. We need to use open-ended questions, do a lot of listening. More listening than speaking is associated with satisfaction from caregivers after the meeting. We need to provide direct support, perhaps from the disciplines who are there, by validating how caregivers are reacting and how we realize they've been doing such a wonderful job of caregiving all along, and that we realize they're going to need time to process the new information and help to make decisions. And if possible, try to achieve consensus. This may take more than one meeting, which is why it is important to end the meeting by letting caregivers know that if they need time to process and digest the information, we'll be willing to reconvene and discuss this in a second or third session as needed. We also believe that a competency in family meetings is to include caregivers explicitly in advanced care planning. What are decisions that are going to be made, and what are the next steps? Do caregivers understand on their level, make sure that we attend to their educational level, their culture, their language, and their understanding of what we are saying? Do they understand what each treatment choice, what the pros and cons are? And if there is no surrogate, we can use the family meeting to help identify a surrogate that can be used if the patient is unable to communicate. At the same time, we should really be attentive to how this family is in terms of their developmental phase and their maturity. Are they cohesive? Is there conflict? Who's in the family composition? Do they have a lot of social support, or are they isolated? Are they resilient? Have they dealt with crises well in the past? Can they draw on resources, or are they vulnerable? And if they are, it is better to identify this vulnerability early on so that we can make appropriate referrals for additional support, for social work support, for psychiatric support as needed. We can use the family meeting to help the patient establish agency, find out if the patient has designated an agent, and if so, does the agent know, and does the agent agree to assume this role? Does the agent fully understand the patient's wishes? Is there a signed healthcare proxy form? Is it witnessed? Does everybody know how to locate it? And is the agent going to be available to make decisions on behalf of the patient? We can also help the patient to complete advance directives during a family meeting, and anything that helps the patient really helps the caregiver to make sure that they understand specific scenarios that may come about in their particular treatment and diagnosis scenario, and specific interventions. Do they want to sign a DNR order? Do they understand the choice in terms of DNI? What about artificial nutrition and hydration? And it is very good to go over all these choices and make sure that they understand the difference between a living will and oral advance directives, and to make these decisions early on. I said it at the beginning and I'll say it again, that a very important competency is to provide direct caregiver support to caregivers during family meetings. We should use active and empathic listening for this, tailor the information so that they can understand it, allow them to speak so we know what's going on for them, explain the dying process if they're going to be involved in a patient death at home or in a facility, in the hospital. They want to know what to expect so that they can prepare, and they tell us this again and again. If we can share decision making, this will really alleviate caregiver burden and also decrease caregiver guilt and recriminations later. And it is really a very good opportunity to respond to difficult emotions if we see those during the meeting. Vigilance in language is a very important skill and competency, and we really have to be careful about the words that we use during the family meeting. If we say that the patient is DNR, that really represents a consent process, not a person. Use of terminology like persistent vegetative state can be very hurtful to family members because it diminishes the humanity of their loved one who is dying. If we say something like, do you want everything done, it implies that the choice is between all or nothing, and that's never a choice that we want to present. So we have to be careful about terminology and language. Hang a morphine drip could be a very good thing for continuous infusion and pain control and relief of suffering, but it may be heard by the patient and the family as, well, I must be dying soon, otherwise why am I getting morphine? And also referral to hospice could be done for the best reasons with the best interests of the patient in mind, but could be misperceived as abandonment by the team. So instead of saying, should we stop everything, perhaps nature is taking its course is a softer way and something to consider. Instead of saying there's nothing more we can do, saying there's nothing more we can do for the tumor, but here's what we can do for the patient and here's what we can do for you. We should never say the patient failed chemotherapy, but rather we have to weigh the benefit and burden of each treatment option, and we don't believe more chemotherapy is in the patient's best interests. And do you want us to do everything? Perhaps we could reframe it by saying, let's do the things that make sense medically for the patient as a person and avoid the things that will not help. There are some wonderful protocols for family meetings. The SPIKES protocol, which has been very well used in oncology and in other fields, which I encourage you to review. There is also OncoTalk, which is training for oncologists to improve how oncologists and trainees respond to emotional concerns and give bad news. Jerry Talk is another wonderful program which improves the preparedness of geriatric and palliative care fellows for challenging communication tasks. And EPIC and LNEC also have training modules for communication and advanced care planning. A relatively new training program is the COMFORT curriculum that's being used in the City of Hope in an NCI-funded program, which involves a 2-day training program focused on real patient-centered, mindful presence approach to communication. They aim for the development of 2 new communication skills, and it comes with an iPhone app, a quick reference guide, and later this year the Oxford Textbook of Palliative Care Communication will be published, which will also further build on this work and give a lot of very good training protocols. So back to our family meeting, our third and final phase, and that is the follow-up phase. In the follow-up phase, we should offer support services in the meeting and then follow up on these afterwards. Perhaps we're going to refer to chaplaincy, to patient advocacy, or get an ethics consultation. We should mention that so that patients and families understand next steps, and then we should follow up on those. We should summarize the meeting content and make sure everyone understands what was discussed. Check in with patients and caregivers again. Was there anything that you wanted us to discuss that we didn't get to? Is this what you wanted from the meeting? And then summarize an action plan with concrete steps so everybody leaves knowing what to expect. And then the person who documents should document who participated, what was discussed, what decisions were made, what still needs to be resolved, and what is the action plan. The documentation should be made available, and additional information should be provided to any member of staff or family as needed. And it's also a very good idea to debrief with staff and find out how they think the meeting went and see if there are any unanticipated problems or follow-up steps that come from their point of view. I think the best way that I can expound on some of these best practices is to discuss two challenging case scenarios that we've recently been involved in, and to tell you how we dealt with those and see how these resonate with your own practice. This is the case of Mrs. R, an elderly woman who is hospitalized for bowel obstruction secondary to occurrence of GI cancer. She's found to have progressing tumor with associated pain, poor performance, immobility, dehydration, and a lot of decreased bowel motility, nausea, and constipation secondary to opioids. She has received chemotherapy and radiation therapy earlier in her disease course, but disease progression followed, and these are no longer options. She's now being treated with opioids, artificial nutrition, and hydration. She has been deemed a poor surgical risk because of widespread intra-abdominal disease and multiple points of obstruction. The oncology team asks the palliative care team for help with symptom management and next steps. The palliative care team convenes a family meeting. It is run by a senior palliative care fellow, a social worker, and Mrs. R's daughter, son-in-law, grandson, and granddaughter. Mrs. R is really in a deep sleep at this point, and she's unresponsive for large periods of time. The family does not wish to wake her, so she does not participate in the meeting. The fellow begins with an overview of Mrs. R's disease progression. He notes the symptoms that suggest she has entered the terminal phase. He offers potential medication management to ease her symptoms and explains how each one of those will work. Mrs. R's daughter is the designated healthcare agent, and she immediately says that her mother would not want to live like this, and that it is her mother's expressed wish to die at home. The family then reminisces, with the help of the social worker and the physician, about Mrs. R's life, her accomplishments, how much they love her, and the social worker then lists the options for where she could die in the way that she wants to die. She could get hospice, she could get hospice home care, or she could go and get hospice in a facility. As the meeting is wrapping up, the chairman of medicine arrives unexpectedly. He pulls up a chair and he suggests surgery as an option. He's very encouraging about surgical resection as a good alternative, and he urges the family to consider more aggressive intervention. The palliative care team is surprised by his arrival and by this information, and the family is confused, and the meeting ends without a clear way forward. Now, in case you're wondering how this was resolved, we did bring in the palliative care attending after the meeting. We reconvened with the chairman of medicine just on a staff level, debriefed about how palliative care saw the issues versus how medicine saw, but the very important message here was not to argue in front of the family, but I do give this case as an illustration of typical pitfalls in family meetings where there are unclear goals of care, someone who comes and gives pathophysiology lectures, which is not what the family needs at that point, the possibility of giving unrealistic hope to the family, and disagreements among professional staff, as well as power struggles. There was a chairman versus a fellow, which is why we dealt with this after the fact. The dominance of medical content meant that there was very little psychosocial focus, and it also highlights the challenging role that palliative care consultants play, because they're coming and giving advice, but they're not the primary team. In a second challenging scenario, I want to introduce you to Mr. C. Mr. C is a relatively young first-generation Chinese immigrant who is rushed to the hospital in a major medical center in an urban setting after complaining of chest pain and collapsing in the bathroom at work. He is accompanied by his wife and soon joined by his 3 children. Mr. and Mrs. C speak almost no English, and they rely on their children to interpret and explain the medical information. And of the 3, the 15-year-old daughter is the most fluent in English. After a cardiac workup, Mr. C is diagnosed with end-stage congestive heart failure and a prognosis of weeks to months. A family meeting is hastily arranged to share the diagnosis and prognosis with the patient and family. And the people present are the cardiologist, the ER nurse, the physician's assistant, and the family. Everybody stands around Mr. C's bed in an open cubicle, and it is now late. The workup took a long time, so it's 10 o'clock on a Friday night. The hospital interpreter has already left for the day, and because it's such a noisy environment, the staff decides against the use of the language line. The cardiologist leads the discussion and uses the 15-year-old to tell Mr. C that he has extensive heart disease, he's going to have to change his diet, his work, and his lifestyle. There are some treatment options, and he could decide which one he wants to choose. She then leaves the meeting and just wants to make sure that the daughter tells her dad the time is short and her father should get his affairs in order, and this is a very serious prognosis. The daughter nods and translates for her parents and her brothers, and the staff notes her calm and mature demeanor in the chart. This case illustrates some very common cultural challenges in working with caregivers of different acculturation levels. It's very tricky to use an untrained family member as an interpreter, and also to use a daughter may ignore a cultural norm in this family where the eldest son really will be the decision maker if the father is unable to make decisions. Truth-telling may also be considered bad luck among some families, and certainly was in this family, and so the cardiologist may have violated a cultural taboo by coming out and saying as much as she did. No one asked the patient if he wanted to have a family meeting or how he wanted information disclosed, and there was no non-medical discipline involved. So using a professional interpreter is always preferable because children become very stressed. They may omit information, and using children is actually illegal in several states. But professional translation is not 100% accurate, so it's important to be explicit and say things like, please translate everything that I say word for word. I'll be explaining technical terms. Let me know if you have any cultural concerns or the word doesn't exist, and we'll work around it. And also address concerns proactively, and these may relate to confidentiality, immigration, language. When working with interpreters, it's very important to still make eye contact and speak directly to the family, not to the interpreter, and then debrief with the interpreter after the meeting. So to end, I will leave you with some questions which have yet to be answered in terms of the family meeting, and all of which would make for wonderful research studies now and in the future? Is the family meeting associated with higher satisfaction, or could it make things worse? What outcomes should we measure? Does the family meeting cost or save money in the end? And do setting, the length of the meeting, the number of participants matter? Should we do individualized planning before meetings, and would that reduce the need for ad hoc and save time for teams? And does the family meeting improve bereavement, which is a question that I get asked pretty much each and every day? So some answers to these questions is that the literature in family meetings is still relatively new, but what we see is that existing studies suggest that benefits outweigh risks. Promising signs are that family meetings in the ICU have been associated with less time spent in the ICU, less aggressive intervention, earlier withdrawal of technology, more timely referral to palliative care and hospice. Model programs have shown the feasibility of collaborating and upstreaming palliative care and hospice referrals from the ER environment, from oncology, from ICU, and some new tools which have come out, self-report instruments, family inventories of needs, and coaching for caregivers can increase caregiver confidence and decrease concerns because it empowers them to participate more actively during family meetings and is, I think, a very promising area for the future. So I will leave you with these closing thoughts. We need to aim high to make sure that caregivers' needs are met. We need high standards in terms of knowledge, clinical competency, and understanding of best practices. Working with caregivers falls to no one specific member of the healthcare team, but therefore falls to every member of the healthcare team, and that means each and every one of us that are on this webinar today. And in my opinion, the family meeting should be a quality indicator in palliative care and hospice. I'm leaving you with some wonderful references, and we are now opening the floor for questions. Thank you very much. I am getting an excellent question here which reads as follows. Is there a best practices way to ensure that we are being honest with a family about a prognosis while still honoring cultural taboos against voicing the diagnosis and the prognosis? And I thank the person who sent that question because it is an excellent question which comes up a lot. And my answer is this. We cannot impose our standards and beliefs from Western medicine on other cultures. We have to sometimes walk on eggshells, but we have to do what makes sense for that family and that culture. For example, we may have to have a meeting without the patient present so that we can share that information with the family first and then decide how to share that information with the patient. Sometimes we may have to use euphemisms, but we want to make sure that it is done with cultural sensitivity and with great respect for the culture and taboos that exist within that family. I'm getting another interesting question, and that is, what are the pros and cons of having the patient actually participate in the meeting? I think we have to be flexible and have an open mind on this point. I read a very well-designed study that was done in an inpatient hospice setting in New York State, where it is the convention and practice of that hospice to exclude patients from the family meeting. They still run very high-quality family meetings because they want to provide a forum where family members can be open and not feel that they have to be protective. They can be more expressive and more honest about the frustrations that they're feeling. And what they do is they then go and debrief with the patient, so they bring the patient into the meeting after the fact. So generally speaking, the rule of thumb is to include the patient if the patient is able, if the patient wishes to participate, if it's okay for that family to have the patient participate, and if it works in that setting. I'm also seeing a question from a setting in which the entire team is made available to participate in the family meeting, and I do think that that is a very worthwhile practice and a practice that we would endorse, but it is really a setting specific, and so not a blanket rule that we would be able to impose across the board. I'm getting another question about how to include family members given the realities of where family caregivers are today. If the family members are scattered geographically across the country and we are concerned that we're running out of time and that there won't be time for everybody to get together and be in the same room at the same time. I have run and seen some excellent family meetings where somebody who couldn't get there on time was able to participate by phone or by Skype and other new forms of technology. So I think we have to be creative. If we can, we should wait until family members get together, but if it looks like it's not going to happen and somebody may be late and a decision has to be made immediately, and I would say that that includes perhaps a member of the clergy. That's very, very important to that family. Those people can really participate. One of the best family meetings that I've done in recent past was with an interpreter over the phone who spoke Armenian and helping a 78-year-old patient to make decisions and really specify her advance directives. And the family was sitting around the table and in the kitchen, but the translator on the phone played a very important role. So that's how I would bring in people from across the country who can't be there. I'm getting another interesting question about discipline. Which discipline is the best prepared to take the lead in a family meeting? Is it a physician? Is it a social worker? Is it another discipline? And the best research that I've seen has the discipline take the lead who is discussing where is going to cover what is very important to that family, so that the physician will take the lead to give the medical update. The social worker will take the lead if the psychosocial factors are paramount. The nurse will take the lead in other situations. For example, the family meeting that I just mentioned was an admission nurse in a hospice who is very, very experienced in running family meetings. So I think that we can be flexible and that we should respect the different role that every discipline brings. And I do think that having different disciplines is not only helpful for family members, but it is helpful for us as well to share the burden, because this work is very complex. And so as long as every discipline has their turn to say what they have to contribute and what they would recommend, I think that it is good to cast a wide net and include different disciplines and be flexible about who is the leader. I think that I have time for one more question, and this is what is the evidence related to different family meetings in different settings, and in particular in the home care setting? There is not a robust group of articles or research studies that have been done in the home setting. There's been a lot of work done in home care in pain and introducing pain management, and that work has been done very well by colleagues of mine from nursing and social work. But anecdotal evidence suggests that the home setting is very promising for family meetings. It is sometimes difficult for different disciplines and professional staff, team members to get to the home at the same time. But if they can, it is very empowering for patients. It is very intimate because we are meeting patients and families on their own turf. It's also very good to have boots on the ground and see how the family is functioning and what their living situation is. So I think that it is a fruitful area for family meetings. It is something which I hope will be reimbursable and studied in the future, because I think that it can be a very logical form. Most of the work in family meetings has been done in the inpatient setting and in the hospice setting, and I think that home care is definitely the next frontier. I see that we have many more questions and that we have run out of time for today's webinar. So what I'm going to invite you to do is to please send your questions offline to me. You can get my email right on the Institute website, and I'd be delighted to continue this conversation by answering your questions one by one. So I want to thank you very much for your attention today, and I am very delighted that so many people were interested in learning more about family meetings as a best practice in hospice and palliative care. I also hope that you will join us for our next webinar, which is going to be palliative sedation, medical, ethical, and legal issues by my colleague, Dr. Pauline Lesage, and that will be on July 23rd at 12:30 Eastern Time. Thank you again for your attention. It has been our pleasure to have you join us today.